Yes, hi everyone from Asia and all over the world. This is the 15th CPD Asia online continuing professional development platform for Asian radiologic technologists societies. Hosting this 15th CPD Asia is the Vietnam Association of Radiologic Technologists, VART, and I am Peachy Luna, your program host. We are again grateful to our sponsor, VT Healthcare Vietnam, in helping us organize the online CPD Asia. And we are live streaming on YouTube. Please search VART channel and PARI channels so you may join us live and watch a replay using the YouTube channels. Now, to formally start the program, please welcome the president of the Vietnam Association of Radiologic Technologists, VART, President Phi Duong for his opening speech and welcome remarks.
Good evening, everyone. Good evening, all colleagues. Dear old friend, new technology in radiology is developing very fast. We will continue it in ASIA CPD. We hope we continue sharing your experience to everyone of Asia country. Congratulations to nine country. We work hard and success. Now we only way welcome on another country. Friend, please join us. Today we start 15 ASIA CPD. Thank you so much everyone for support for us. Now we start. Thank you, Peachy Luna.
Yes, thank you very much, President of Vietnam Association of Radiological Technologists, VART, President Phi Duong. This online Asia CPD is highly supported and graced by member societies, presidents and officers and their representatives. Allow me to recognize them. Let us greet and welcome the President of Macau Radiological Technologists Association, MRTA, President Fernando Kok.
Hello, good evening, everyone.
We have also the President of Indonesian Society of Radiographers, or PARI, President Diek Subianto. We have also President of Hong Kong Radiographers Association, HKRA, President Wan Shin Buon Nelson.
Hi, everyone. Good evening.
Yes, good evening. We have also President of Taiwan Association of Medical Radiation Technologists, TAMRT, President Chun Yuan Tu.
Hello, everyone. Good evening. Thank you.
Also, we have tonight the Singapore Society of Radiographers, SSR President, President Denise Truong.
Good evening, everyone. Thank you for joining us.
And joining us again is Yin Yin Tan of the Myanmar Society of Medical Radiation Technologists. Yes, also we have from Malaysia, we have Madam Chan Lai Kwan.
Hello, everybody. Good evening to all. Nice to see all of you again.
And we have also from MRTA, Sir Jerry Pedro Lay. Yes, we are also grateful to President Sophie Lee of the Association of Cambodian Radiological Technologists and to President Rolando Banyares of the Philippine Association of Radiologic Technologists. Thank you very much, dear presidents and officers. Later, they'll be joining us again in the Q&A session as our panelists. May I respectfully request everyone to please open your camera for a simple photo ops. All right, thank you very much. Now, to formally begin the program, allow me to introduce our program moderator, who will facilitate the introduction of our two great speakers and the Q&A session later. Please welcome Mr. Liu Phi Duong.
Thank you, Peachy Luna. Good evening, presidents, panelists, and participants. My name is Phi Duong, and today I'm very honored to welcome all of you to the 15th Continuous Professional Development held by Vietnam. At this conference, I would like to introduce two Vietnamese speakers. We will present the impression topics cardiac MRI, with many experience and newest updates of the techniques and also the clinical. We hope that their presentation will provide more knowledge and interesting insight about cardiac MRI. Hereby, we look forward to receive many questions and discussion from all of you in the Q&A session. And for the start, please welcome the first speaker, Mr. Hoang Truong. He's an MR clinical application specialist of PE Vietnam. His presentation is cardiac MRI, update newest protocol. Please, Mr. Nhan.
Okay, so thank you for Anh Dũng. Okay, hello everyone. So my name is Nhan Truong. It's my really pleasure for me to be here today for joining the 15th ASIA Continuous Professional Development. I would like to share to you. I would like to share my screen first. So I would like to share to you some update about the Cmr technique and what the technology is developed and provide to have our Cmr examination become more and more simple and productive, and it also have to acquire the consistently superior image quality to ensure the patient comfort, and to gain the clinical diagnostic confidence as well. Let's have a look on the latest Scmr and AHA frontline testing guidelines for the chest band. You can see that the application for our Cmr. I need to change to the laser point. For the new guideline, for the update guideline, the Cmr is comparable to other modality like PET or stress ecography with the classification, the number 1 or 2A is mean that the Cmr right now is becoming more and more comparable to other image modality. Like there are some publication to show that there are some multi-center trial that to validate the change to prove that the Cmr is non-inferior to invasive cath. So that's the reason I believe this is the huge change, the huge gain for cardiac MRI, and lead to the wider application in the clinical needs for Cmr, stress perfusion as well as non-stress perfusion Cmr. Just a quick review about the basic cardiac imaging. We provide excellent assessment of cardiac function using the Cmr technique, Cmr technique, and we also have the black blood imaging to detect the myocardial edema, or we can also assess the area at risk or the hemorrhage, or just simply assess the myocardial morphology. So we also have another first pass perfusion to help us to assess the myocardial blood flow or the myovascular defect. We also have the last one in the standard cardiac imaging is the delay enhancement, will help us to identify the myocardial injury or to evaluate the viability of the myocardium. In the case, as you all know that for the CMR protocol, we usually have to apply the sequence as short as possible because we need to get the patient breath hold to ensure the image quality. That's the reason why sometimes we have to we must receive the imaging with low SNR or low visual resolution or lack of the SNR. So the question is that how can the GE have to overcome the challenges to get the right image quality? So my first answer is the ARICOM-DL. So this is a big feature that GEs are so proud of and has been released recently. In the past, as you all know that noise in the images is usually due to when we acquire the too high spatial resolution image or to short up the scanning time during MR signal acquisition. So the current solution at this moment now is to reduce the spatial resolution or increase the signal to noise ratio by increase the signal average. It means that we need and this adjustment may lead to the how can I say may lead to the impact on the productivity. I mean that you have to scan less patient per day. So with ARICOM-DL, we can create imaging with less noise through deep learning reconstruction. So at this moment, people just keep talking about the AI, artificial intelligence. So this new feature is based on that. This has to reduce the need to do the balance between the resolution and scanning time. That means that you are able to scan more patients per day while maintaining the image quality. So luckily, at this moment, ARICOM-DL is available to on up to these sequences and offer us the opportunity to reduce the noise, reduce the ringing artifact, and increase the image sharpness. So so where ARICOM-DL play into the CMR protocol, so the sharpness to see the smaller structure, the thinness line to see more tissue, free breathing for patient comfort, and improve the contrast to noise ratio, and so on. Luckily, ARICOM-DL are now integrated with on of the mostly with almost standard CMR protocols sequences like from function, morphology, perfusion to myocardial delay enhancement. And I will show you in the separate example below. As I mentioned, ARICOM-DL is pioneering deep learning based reconstruction algorithm that improve the SNR and also improve the image sharpness. So sometimes it's not sometimes it also enables shorter scanning time. So in overall, it improved the image quality at the foundation level by impaction on the raw data. We can have a look on the MDE example. ARICOM-DL, you can see the conventional MDE imaging. You can see it's quite noisy, but with ARICOM-DL, we can gain the better outcome with noise reduction, and also the image is more sharper and clearer on the right side here. Another example, to prove the break outcome of ARICOM-DL, will provide the same spatial resolution on the single shot MDE compared to the conventional MDE imaging. As you all know, normally the 2D MDE, we need the patient to break their hole to ensure the image quality. So in the case the patient cannot hold their breath, the alternative solution for patient with this condition is using the single shot MDE with a free breathing. However, with the single shot technique, the image may lead to the blurry, and also sometimes it collect up the SNR. But in this case, you can see the difference. You can see the average MDL also have a lot to maintain the image quality compared to the condition conventional MDE protocol. So beside that, G also focus on improving the MDE acquisition to gain the better contrast and image quality, because you all know that the MDE plays an important role in identifying the myocardium disease. So this is MDE portfolio from GE protocol. We have the 2D MDE conventional one with the gold standard for MDE. We also, and then the phase sensitive MDE for like that, which is less dependent on the inversion time to separate the myocardium. We have another innovation like a single shot MDE as a single shot phase sensitive MDE, as I mentioned. It comes with the pre-breathing to gain the patient comfortability. So and also the last one on the MDE portfolio is the 3D horn heart MDE. So we also have the wideband MDE for it's also compatible on all MDE frequencies on both on 1.5 and 3 theta to help to gain the better image for the patient with the compatible MRI compatible implants. So I would like to mention a bit about the single shot MDE. Single shot MDE. This one is just a moment. With many, because as you this one we have a lot of benefit on this single shot MDE. We can have scanning the horn heart MDE imaging is only one scan. We can acquire the acquisition with the shortened breath horn or even with the free breathing available now. We can reduce the motion correction, and it's also very beneficial to the patient with a high arrhythmia. So we can have a look on the example for the MDE conventional MDE with the patient poor breath holding. We can see a lot of motion artifact on the images, but in this case we can try to another solution. The solution for this patient condition is using the single shot MDE. You can see it's overcome the challenging of motion artifact, and also it shows clearly the hyper enhancement on this area. Another MDE technique I would like to introduce to you is dark blood phase sensitive MDE by applying the proper inversion time to separate the blood pole signal. You all know that the contrast between the normal myocardium and the plus is very important to delineate the myocardium wall. So normally, as you all know, that normally the blood pool in MDE circuit has the high signal, but with this technique, the blood node may be darker than the myocardium. So it providing better contrast between the blood pool and even the myocardium infarction and also the normal myocardium. So basically, the technique also have avoid the waiting time for the washing out phase, because sometimes we need to wait for the signal of blood pool decrease, and this time it happen in the washing out. With the blood wound is darker, so the visualization of hyper enhancement is improved. You can see the example in this image. This one is with the single shot phase sensitive NDE, but the TI set for suppressing the remote myocardium. The blood wound still bright. We cannot see clearly the enhancement, but compared to the single shot MDE, with the dark blood, we can set up the TI for suppressing the blood wound. You can see better the hyper enhancement. So this technique has only this advantage is the penalty of the 6 SNR. So however, luckily right now GE also have the ARICOM DL, as I just mentioned. This is a solution for this technique to overcome the challenges and to get a better outcome for MDE imaging. Another improvement of NDE portfolio is applying the wideband and adiabatic inversion on both 2D and 3D image. This technique have, I believe that this technique have to improve better the contrast between the myocardium because better contrast because it's suppressed uniformly the better myocardium, especially on 3D. On the area with near to the MR compatible implants, on the area with that have B0 and B1 in homogeneity, you can have a look on the right image. On the first, you can see the conventional MDE. We can with the area near the implants. We can see this image suffer the artifact from the implant. It leads to the hyper enhancement on the myocardium, but with the MD plus, we can see the improvement on the imaging. So we don't see any artifact here. Yeah. So another new feature in cardiac imaging is motion correction, which is used with the to make the proper first pass perfusion, because motion correction right now is using the image registration algorithm to compensate the misalignment by respiratory motion and residual cardiac motion on both 1.5 and 3 Tesla system. You can see clearly the improvement in the example on the left image with the MOCO. You can see there are lots of motion artifact. But when it comes with the right image, it's more stable on the right image because the motion correction is applied. Furthermore, another example of the MOCO motion correction is on the luckily the motion correction is also compatible to ARICOM DL. So you can see the first one. The image suffer a loss of motion artifact, it also lack of signal, but in the motion artifact is coming reduced with the motion correction, and the last one is a good combination between the motion correction and ARICOM DL to get the best outcome for the first pass perfusion imaging. Besides that, motion correction is also compatible to T1 mapping, and you can see that in the image, the motion correction have to give the better delineation of anterior and anterior-lateral segment on the left on this one, while without motion correction we can see the image quite blurry. So this leads to with the T1 map with the motion correction, we may have to improve the accuracy of T1 estimating. So a quick review about typical protocol to evaluate for heart attack. So the majority, as I mentioned above, the majority of sequences in the protocol is compatible with ARICOM DL, like Fiesta, black clot imaging. We also have the improvement, a lot improvement on MDE protocol, and perfusion, also compatible with Ericom DL, and also compatible with motion correction to get the big outcome for the perfusion. And I also this one is also the big improvement in cardiac imaging. So the other advanced tissue characterization is the cardiomaps that I would like to introduce you to today is following the information of the Scmr protocol, the update in 2020. Beside the protein morphology sequences that people that you have known before, these guidelines have also specific requirement on advanced cardiomap per second, like a T1 map, T2 map, T2 star map, because this kind of sequences is important because it helps to quantify the change that occur in the myocardium based on the change of the T1, T2, T2 star relaxation time of the myocardium. So there are some specific technical recommendations following the Scmr protocol. For example, the T1 mapping must use the technique of look. I'm sorry. For example, T1 mapping using the only Molly or a shock Molly for the calculation. For another recommendation is for calculation of the ECV must have the time gap. It means that the time between pre and post contrast. So the recommendation is the time one between 10 and 30 minutes post contrast bolus to get a good outcome, to get a good calculation of ECV. Or in T2 mapping, we can see a variety of options, like we can use the T2 repair single source, free precession sequence, or just using the fast pinnacle space per second. In GE, we also have provide a lot of effort to satisfy the technical requirement from Scmr. The first one is T1 mapping with Molly technique, or we can say that the modified look-log curve inversion recovery. So this one is based on the inversion recovery pulse of the steady state radiant echo combined with the motion correction, as I just mentioned, to reduce the motion artifact from breathing. So you can look at on the pundit side, we can see there are two 180 inversion pulse here. So in the first for the first inversion pulse, the signal is received at 5 different TI time, and there will be a 3-bit recovery period that period is needed for the longitudinal magnetization to be recovered before the next inversion recovery is applied. So in this inversion recovery, we apply another 3 different echo. At different time of TI. So sometimes in practical field, so you may hear a few different Molly technique like 533 or 511, and that's the main difference, because when we change the design of the signal acquisition of each inversion point, we will receive like for example in 511 we receive for the first inversion we receive 5 times this here, and what we have we receive only 5 here, and we also just 1 bit recovery, and the last inversion point we receive only 1. So that's I just give you an example. And for this technique, this is a recommended technique by Scmr to evaluate the number of myocardium condition like myocarditis or amyloidosis. This disease is increase the native T1 value or the disease to decrease the native T1 value, like in iron overload or Fabry disease. That is why quantification of native T1 value is considered as a promising method for detecting myocardial injury without the use of the gadolinium contrast. So basically, the normal myocardium T1 value have been reported around 950 to 1000 milliseconds at 1.5 Tesla, and on treaty is around 1100 to 1250 on treaty. So the normal post-contrast Morley technique has been reported to be around 340 to 579 milliseconds. However, this reference number that I found in some article in a certain research of institution. So the recommendation is from Scmr is that the normal value of native T1 should be built up in your own medical facility. So for the cardio map, we also have another technique we call Smart T1 map, because this technique is similar to the Morley technique, but except that we use the inversion punch, but at this case we use the 90 saturation punch. This advantage of this technique is less sensitive to the change of the patient heart rate or other imaging parameters. So in principle, the Smart T1 technique, it can be used for patients with an unstable heart rate. So you can see the design of the Smart T1 punch. As I mentioned, it just use the continuously 90 saturation punch. So this have to obtain the true T1 relaxation of the myocardium. However, this technique right now is not recommended by Scmr because the technique precision, which is defined the ability to reproduce the same result in separate measurement, is less than T1 Morley. Therefore, Scmr guidelines doesn't recommend it to use Smart T1 map for the evaluate the myocardium. So another important indicator is calculation of ECV map, which is this one is calculated based on the T1 map before and post contrast injection. The myocardium, the myocardium, you all know that the myocardium is divided into the cellular and extracellular components. So the extracellular space is important for the structure and function of the heart. So sometimes the expansion of extracellular in some certain condition is a specific feature for cardiomyopathy, and it also play an important factor in the ventricular remodeling. So that's why the evaluation of the ECV is necessary, especially in some disease like myocarditis, amyloidosis, or diffuse fibrosis. Another important about the ACV calculation is not just only based on the T1 relaxation value of the myocardium, but also calculated based on the hematocrit. So the recommendation from Scmr is the hematocrit test should be required within 24 hours to ensure the accuracy of ECV calculation. So the next technique I would like to talk about is T2 mapping based on the principle of the single source fast binnacle black blood imaging is acquired at different TI time, at least 4 TI time. we can after scanning, we will receive the T2 relaxation curve and also T2 mapping. So this one will help us to quantify the T2 relaxation time for the myocardium. This quantification is very valuable in some certain condition, like some pathology that cause the myocardial edema, such as acute myocardial infarction, myocarditis, stress cardiomyopathy, sarcoidosis. So the reason why the T2 relaxation is prolonged in the myocardium is due to the increase of the water content in the myocardium. So normal myocardial T2 value right now have been reported. The normal one have been reported to be on 1.5 to be around 52 milliseconds, and on 20 is around 45 milliseconds. On this example, you can see the mean T2 value of myocardium is 80 milliseconds. So we can see that the T2 map have to detect the edema in acute phase, while the T2 value of medium in this case 80 milliseconds is higher compared to the sign normal T2 value is below than 58 milliseconds. For T2 star mapping based on the multi-echo radiant echo technique. So we acquire the different TA at least 8 echo. So due to the principle of the radiant echo sequences, it will be very sensitive to the change of the local magnetic field compared to the spin echo, because you all know that for the radiant echo, we don't use any prefocus punch to reface the spin. That's why this is sensitive to the local change of the local magnetic field. So basically in this case, when we have the a loss of ion deposition in the myocardium, so we can see that in this patient with sickle cell disease patient, we can see the signal growth in the myocardium. So for your information, that the cardiac failure due to the ion overload remain the most common cause of death in patients in the developed country. So therefore, if we have the alternative and reliable method like T2 map, we can detect and evaluate early the extent of cardiac ion deposition and before the cardiac failure. So based on that, we can control the mortality, the death rate among these disease. So for the normal range of T2 star map, it should be in the cardiac. It should be over for the normal range. It should be over than 20 milliseconds. So we can classify the ion overload based on the T2 star value. For example, like if the T2 star value is less than 10 milliseconds, we can consider it's the server, or the T2 value is from 10 to 15 milliseconds. We can consider it's a moderate ion overload, and if it's over than 20 milliseconds, we can consider is a normal one. So this is a review of Mestroli and other on the Journal of Cardiovascular Magnetic Resonance in 2017 to show that how the relaxation time change in certain type of disease. For example, the value of native T1 value and the T2 value increase significantly in the myocarditis. But it's just slightly increased for the value of ECV in the myocarditis. However, on the ion overload, you can see that the native T1 or T2 or T2 star value decrease dramatically, and you can also see the changes in other disease like amyloidosis or Fabry disease or diffuse fibrosis. So this is an example about the cardio maps on amyloidosis. as I mentioned above, the normal value of relaxation map should be built up and validated in their own medical facility. So in this example, the size normal value of T1 value is around 930 milliseconds, while the EC value is considered below than 28% is normal. While in this patient, the native T1 is increased to 1,171, while the ECV value reached to 84%. Similarly, on the same patient, the value of T2 map of myocardium on this patient is around 67.8, compared to the size normal range is below than 58 milliseconds. So therefore, based on that, we can see that the marked elevation in value of native T1, ECV, T2 are the very specific image feature on this kind of disease. So another case study with a male 27 years old. He's an athlete coming to check up with the Disney palpitation, but without any clinical history. So Cmr is performed on this patient with routine morphology for 2-chamber Fiesta, 3-chamber Fiesta, and 4-chamber Fiesta with the following the image parameters. We also the function assessment on left and right ventricle are also be done on this patient. You can see the ejection fraction of this patient is in the normal range, which is ejection fraction left ventricle is 65%, ejection fraction right ventricle is 63%. On the T1 mapping, with using Molly 533 technique, we acquire the T1 focal area with the high T1 value. You can see 1,180 and 1,123 compared to the normal value of site is 930 milliseconds. So the elevated T1 native values result in the increase of ECV in the same focal area. You can see here. At here we see the 33% of ACV and 37% of ECV compared to the normal value outside is 25.3%. So the MDE technique also performed on this patient. It saw three contrast enhancement area in the myocardium. So this one is confirmed. This one is then confirmed as the focal fibrosis. This patient is finally confirmed as the hypertrophy cardiomyopathy with local fibrosis. So you can see the important role of the cardio map in Cmr through this patient. Obviously, the Cmr is a good tool to diagnose and follow up the hypertrophy cardiomyopathy. So cardio maps also, especially T1 map and SCV, help a lot to stratify the risk of cardiac event. We also have another example of cardiac case is patient with viral myocarditis. In this patient, the ejection fraction is in the normal range. As you all know that the ejection fraction is the normal range is about 50 to 75%, following the American Heart Association. So in this case, the patient ejection fraction is in the normal range. We also noted another very cardio effusion on the Fiesta kinase imaging. On the MDE, we see this. Also, we see the enhancement area. You can see the red arrow and yellow arrow. In terms of the cardio map, you can see the high value of the T1, of the T2, of the T1 and ECV compared to the normal value outside. So as you all know that since for a long time, CMR just have to quantify flow, volume, ejection fraction. But with the T1, T2, and T2 star map, the more and more quantification are available now. So the MR modality has become a right tool in detect the non-ischemic cardiomyopathy to follow up the patient as well as the prognosis. In this case, you can see in acute phase, acute phase, you can see the high value of the cardiac mass compared to the normal value. But after 3 months follow-up, you can see most of the value is coming back to the normal range. So the cardiac, so we can conclude that the cardiac MR with mapping can place as a biomarker for following up and prognostic at different conditions like amyloidosis or myocarditis in this case. So the last technique I would like to briefly introduce to you is 4D flow. This is much improved per second compared to the traditional 2D 2D flow, because at this moment 4D flow is quite commonly used to evaluate the flow in the congenital heart disease or evaluation of shunt, or it's used in the valvular disease, or sometimes for the evaluation of rectal vessel like aortic disease. So how this issue is how this sequence being improved. So you can get back to the 2D phase contrast flow before. So that technique we need to take a lot of time to apply the image over and over again, because because sometimes the patient cannot depress, so we have to take and scan again, and sometimes the technologists don't have enough experience to identify the scanning lane, the proper scanning lane to assess the flow. So that's a reason why it takes time to do, sometimes to do for the 2D flow. So with 4D flow, we use the free breathing technique, and we also use the acquire the horn heart acquisition. So we don't need to care about the proper scanning plane to assess the flow. So beside that, because it is a free breathing technique, so it may have to improve the workflow. In addition, 4D flow also make the patient more comfortable because of free breathing technique, and allow us and sometimes it allow us to apply the image of younger patients without any anesthesia. So because this technique is indeed independent to breathing, so this technique sometimes it can be shorter, and it leads to the shortening the overall CMR protocol compared to the conventional one. So this is a example case for patient with a mitral bioprosthesis with the 4D flow technique. So the bioprosthesis has become stenotic as seen by the cardiac ecography. So 4D flow show accelerated flow. You can see the red vector, a lot of red vector here in the mitral valve. With a significant pressure gradient. Beside that, 4D flow also show the severe mitral regurgitation, but this one is not reported, reported by the cardiac ultrasound. So that's the end of my presentation today. Hopefully, I hope that it's help to update to you in the latest technique of CMR nowadays, and may help you in your daily clinical practice. And thank you very much for your attention.
Thank you to Mr. Nhan for your sharing and updating newest techniques and protocol in cardiac MRI. We hope that the attendee and participant will get more knowledge from your sharing. And all of you can use Q&A box to make your question to speaker in the Q&A session. Thank you. And now we will move to the second speaker. Please welcome Dr. Phi Duong. He is a specialist of imaging cardiac medical center, Vietnam. His presentation is emerging techniques in cardiac MRI. Please, Dr. Duong.
Hello, everybody. Mr. Duong, can you hear me?
Yes, I can hear you. Please start.
Yes. Good evening, Chairman. Good evening, ladies and gentlemen. I am Dr. Duong Phi. I work in the Department of Cardiology in the Medical Center, Vietnam. Today, I talk about the emergency technique in the cardiac MRI. Until now, a lot of new technique in the cardiac MRI, but in my center, usually the scan the patient another hospital in the Ho Chi Minh City send my center to diagnostic, and my center has the cardiac CT and the cardiac MRI, and I see every day the doctor in the Ho Chi Minh City send my center if they want to diagnostic the ischemic heart disease or the coronary disease. They usually provide the coronary CT scan, and some the patient has the non-ischemic heart disease or non-ischemic myocardiopathy or the tumor or the congenital heart disease. They want measurement about the measurement about the right ventricle, the volume and the function. They usually provide me the cardiac MRI scan. And today I only talked about the imaging technique. I usually use every day in my center. You know, the cardiac MRI has become more important in the diagnostic and the risk certification of the cardiac disease. And cardiac MRI modality is the gold standard for the evaluating the myocardial mass, function, and the volume. Cardiac MRI is the unit's ability to provide a detailed tissue characterization. For example, myocardial edema, perfusion, or the fibrosis. And I think cardiac MRI will be the widest application. Until now, we have the new techniques such as the T1 mapping, T2 mapping, extracellular volume ECV, or the T2 star mapping. And recent advance in the image recomposition technique have the potential further increase the clinical utility of the cardiac MRI. Artificial intelligence AI in the algorithm will automate segmentation of the volumetric and the function of cardiac chamber. And how is the T1 mapping? T1 mapping is the quantitative technique by the T1 relaxation time of the myocardial vessel can be measured and mapped of the T1 value rating. And T1 mapping play in the important role in the patient with the diffuse or the subtle change in the myocardium. And that cannot be detected by the visual inspection of the ray care image. I think either native T1 either reconstruct T1 mapping. And the normal native T1 values measure with the Muli as the 1.5 Tesla, about 900 to the 1100 milliseconds, and T1 approximation were reported about 14 to the 28 later with the 3 Tesla. With if the increase the native T1, we usually see the edema in the infraction or the inflammation, and other interstitial phase increase, we usually in the fibrosis or the interfiltration amyloidosis. And how is the low native T1? We usually see in the lipids or the iron overload. And this slide showed about the values of the normal T1, normal native T1 in normal and in green. We usually see in the hypertrophic cardiomyopathy, myocarditis or the amyloidosis, and we see the low native T1. We usually in the fatty metaplasia or the iron overload or the paridising. And we have the K example, the patient, the old man, 55-year-old in the Ho Chi Minh City. His family no heart disease and he no hypertension or no painting. He usually palpitation and angina. His ECG and echocardiography showed about left ventricle hypertrophy and ischemic heart disease. The doctor required the patient before the coronary CT to the suspected, because they suspected the coronary disease. And when we scan coronary CT, we see the 3D, the 3 vessels of the coronary here, LAD, circumflex, right, coronary artery, and the circumflex is normal. And we see the ASIAN view, we see the interventricular sector severe thickening. The patient suspected about the hypertrophic cardiomyopathy, and the patient, the doctor required the patient cardiac MRI with the contrast enhancement. And we see the scene imaging. We see the basal and mid sector is severe thickening about 22 millimeter, and the basal and mid anterior thickening about 22 millimeter, and the mid inferior about 21 millimeter. The patient has the hypertrophic cardiomyopathy with the left VOT no obstruction. And we see the legs imaging. We see the legs in the micro as the anterior sector and inferior sector. And we have the software to measurement about the leg mass. This patient has the 49 gram and the ratio of the leg mass and over the left ventricle mass about 27%. The patient has the high risk, and we use the T1 mapping to measurement about the native T1 in green about 1,117, and in green the ECV about 46% here. And how to the extracellular column ECV either T1 mapping is performed before and after the contrast enhancement, and we have the operation to calculate it and the map distribution of the myocardial extracellular column, the impression here, and the normal ECV values of the 1.5 Tesla about 25%. And increase the ECV, we usually in the implementation in the myocarditis or edema, we usually see in the cardiac in myocardial infarction or the focal fibrosis in the non-ischemic myocardiopathy, and the infiltration in the sarcoidosis or the amyloidosis. How about the low ECV values? We usually see in the thrombus or the lipomatic metalasia. And you know, the myocardial tissue, about 75% of myocardial intracellular tissue, and about 25% consist of the extracellular volume. And with the fight between the on cell, this is the cell, this is the cell, this is the between, including plasma in the vasculature here. And the slide sort of the patient had the fibrosis in the extracellular and the fibrosis here, and the intracytil we see in the amyloidosis, and the edema we see in the inflammation here. And the image showed about the normal extracellular, and we see the increase the hypertrophic cardiomyopathy and increase the infraction or the amyloidosis. And the second case, for example, the patient has the hypertrophic cardiomyopathy, and when the ECG of the patient suspected ischemic heart disease, the patient, the doctor requires the patient cardiac MRI to diagnosis of the hypertrophic cardiomyopathy, and the exclude about the coronary disease. And we see the CNA, we see the basal, mixed, and septal, the severe thickening about 70 millimeter. The patient had the hypertrophic cardiomyopathy without the left ventricle obstruction. And we see the rest perfusion, so the subendocardial hypoperfusion here as the apical inferior. This is the patient has the stenosis of the coronary. And we see the legacy two chamber and short view, the subendocardial fibrosis here. We see that clearly, and in the apical inferior, this is the scale of the ischemic heart disease, not the myocardial myopathy, non-ischemic cardiomyopathy. And the patient has the legacy mass 6 gram, and the radial legacy mass over the left ventricle mass 4%. The patient scan the coronary CT has the stenosis of the 50 stenosis of the middle right coronary. And the patient has the increased myocardial native T1 in the 1,108 millisecond, and the increased ECV about 29%. And we continue to talk about the T2 mapping. T2 mapping is the quantitative technique by the T2 relaxation of the time its myocardial bit cell can be measured, and a map of the T2 values criteria is very important to provide the presentation of the inflammation or the edema, then scale the T2 image. And normal T2 mapping about 52 milliseconds as the 1.5 Tesla, and if the 3 Tesla is about 45 milliseconds. If the increase the native T2, we think the myocardial edema. We usually in the acute myocardial infarction or acute myocarditis or the chest cardiomyopathy or the sarcoidosis or the cardiac germline rejection. And for example, the K3, the patient has the myocarditic were the diagnostic by the original blood fluid criteria, and the young man about 40 years old, he present the fever, tired, and chest pain. The patient go to the emergency department with the ingredient turbidity and the ingredient CMR. His ECG show the regular sinus rhythm and the ST direction after D2, D3 AVF and V4 to V6, and the patient has the interventional the coronary angiography and no tendency of the coronary detected. The patient can cardiac MRI on the following admission. The T2 weighted, so we see the region signal intensity increase here in the apical lateral, and increase the intensity the basal anterior lateral, and the ratio between the myocardium and cervical muscle in the T2 weighted before radiodium overture, and we think is the edema of the myocardium. And the legate, so we see the subepicardiofibrosis, the apical septum, and the scare in the basal anterolateral, the Langerhans mass about the forearm, and the radial Langerhans mass and the left ventricle mass and about the 4%. The patient here, this is the original blood fluid criteria we see here, and now we has the new blood fluid criteria. We use the T1 native or T1 mapping ECV and the Langerhans, and combined with the ingredient T2 mapping and the region high in the ratio of the T2 weighted here. This is the new. And we has the young man about 19 years old who presented fever, tired, and chest pain of the left side. The patient go to the emergency and has the ingredient turbidity and ingredient CRP. The ECG show the negativity way and ST direction V4 and V6. The patient in interventional coronary angiography to the no tendency of the coronary, and we see the cardiac MRI. So in the recent signal in intensity ingredient T2 weighted, and the ratio between the myocardium and the cervical muscle here before gadolinium overture, and the latest showed about the subepicardiofibrosis as the apical septum and the mid anterior lateral. The latest about 10 gram and latest mass over the left ventricle mass about 11%. And the patient has the ingredient myocardial native T1 and the ingredient native T2 about 56 milliseconds, and ingredient ECV about 29%. And how about the T2 star mapping? We usually characterize in the common cold death in the patient with the thalassemia, because the patient has the iron overload, and the T2 star mapping allow the detection and quantification of the iron deposition in the earlier stage, as well as we monitoring the treatment response or the efficacy of the chelation. And now star mapping, helping you detect the intramyocardial hemorrhage, the S1, at first the prognosis market in the acute infarction. And we had the software to the by the AI artificial intelligence application in the cardiac MRI. Maybe the AI simplify process volumetric function analysis of the cardiac chamber. Several studies show the automatic the segmentation with the result superior to human evolution last time. The AI automatic segment are the currently FDA licensed and commercially available. And my center has the new software to the measurement about the volumetric and the function of the left or the right ventricle. We see the image showed about the diastolic phase and the systolic phase, the automatic the segment about the function and the volume of the right and the left ventricle. And application of AI in the cardiac MRI, maybe we see the myocardial fibrosis and the scarring can be made systematic by the quantified automatic by the RE algorithm. For example, here, and when we scan the cardiac MRI, we use the software, the new software to measurement about the scale here, automatic measurement. Then we see the length about 24 grams and the length over the left ventricle mass about 17%. And now I see the automatic deep learning algorithm has shown the ability to detect the myocardial scale by non-contact enhancement with the cine imaging. And now is the reason. Conclusion. In the recent year, cardiac MRI recently used for diagnosis and the treatment of the cardiac disease. I think cardiac MRI will be more still diagnostic tool in the future. We have new techniques such as the T1 mapping, T2 mapping, T2 star mapping, or the ACV will be adopted widely in the routing cardiac MRI examination. AI algorithm will eliminate artifact and the shorten scan time and so improve image quality so much. Thank you for your attention.
Yes, thank you. Thank you to Dr. Seung for your valuable clinical experience of emergence techniques in cardiac MRI. And again, thank you to speaker for your very good, very well presentation to us. And now we'll move to the Q&A session. Firstly, I would like to invite the panelists to discussion and match a question to speaker, please. Yeah, please, panelists, to open and have question to speaker.
I have an idea because you know, everybody know 3 years ago cardiac MRI not useful now, but now emerging in cardiac MRI because maybe AI developed and together work together develop AI develop, and now we can diagnose this for some cardiac myocardial in MRI. I think that emerging. I know I want to hear share from some in Hong Kong and Macau and Taiwan and Singapore and Philippines. You can share in your experience for everybody. I think the first I would like to invite the specialist MRI, Mr. Lee, from Taiwan. I remember in last time we have an expert how you cardiac MRI in you use in Taiwan. Miss Lee, I invite Miss Lee, Chen Hu Lee. Miss Lee, he very specialist MRI. How about cardiac MRI? Miss Lee. You mute the microphone. Unmute, please.
Okay, just wait a moment. Okay, so you can hear me?
Yes, I hear.
Okay. Thank you. I think cardiac MRI is very interesting issues for clinical use. But actually, in our hospital, that we don't have so many experience about this field. But I think it is very interesting. So I think because we don't have we just don't have so many experience about this. So I think let me see. Maybe not, and maybe other countries or areas. So maybe they have a more better experience about this. So maybe they can share some issues or some their experience for us.
Yeah, thank you. Okay, how about in Singapore and Hong Kong? You know about the cardiac MRI in your country now. In Macau, you using DME, for example, DME.
I can say something.
Yes. Okay. Good. Okay.
Yeah. Okay. Hong Kong actually always do the MRI for the cardiac disease, and yeah, as I know before, we just use the T2 star only, or a little bit late get for the laser enhancement for the myocardium. So nowadays the technology is quite advanced, and we use the sequence like the speakers what they told me about the T1 mapping, T2 mapping. They're widely used recently in these few years, and really useful for those patients with some other pathology. And for the pandemic period, and we also encounter some post-vaccinated patient for their myocarditis. So there are quite a lot of some teenagers, they take the vaccine and become the heart not feel very well, and they find that they have the myocarditis. So in that case, they refer the teenage to come to our hospital for the MRI cardiac, so that to see whether they have such a disease, something like that. So I think the MRI is quite widely used in the Cmr already. So so that's my experience actually. But also, and recently our hospital installed a new MRI machine, and we found that just like the first speaker, and there is the AI software. So in GE, they what we call the deep learning. So in Siemens, they will call the deep resolve, and it really good. Yeah, from my experience. What do you mean? Because we can scan the same sequence, but just within a short period of time. But in return, you'll receive a quite you can't expect a high quality of image, so that the radiologist can do the image, the diagnosis very easy, what we call it. And in the other terms, I think the technologists can shorten the scanning time. As you know, if you have any experience in MRI, I think the challenge is the scan time for those patients. At least every sequence 4 minutes, 5 minutes, and as a whole at least 30 minutes or nearly 1 hour for the cardiac MR. So if all the technologists can help the whole exam can shorten the scan time, I think that will help the patients a lot. So that's my experience, and I think others can share also.
Okay, before I ask Mr. Nhan and Mr. Nhan, I want to ask Singapore in how Dennis, you know, in about using a cardiac MRI in Singapore now. Dennis, you know.
Thank you, Mr. Loh. So we have cardiac MRI services at our hospital. But unfortunately, that's not really my area of expertise. So really, I was just very blown away by all the new developments in cardiac MRI. So I was really just learning for this. But I know it's a very specialized scan in my hospital. So like even I think like it's usually performed by the senior radiographers, the ones who have additional special training. Yeah. So like President Nelson also said, right? A lot of especially these complicated MRI scans require a lot of planning, especially if some of the patients require sedation as well. So it really takes like a good and well-working team to be able to optimize this and make it efficient so that it's comfortable for the patient as well. Yeah. So I'm sorry, there wasn't very much that I can contribute on the technical side, but I appreciate that. This is a very important and also a very technically challenging scan. So the advances that were shared by our first speaker, Mr. Nhan, right? I think will definitely help in terms of like the image quality and the comfort for the patient. Right. Thank you.
Thank you, Dennis. Thank you, Dennis. Another panelist, you have a question for the speaker?
Yeah, may I have a question? Okay, I would like to ask a first question to first speaker. Could we use a single shot MDE is a delay or without contrast? Right? Delay sequence or without contrast sequence? Single shot MDE.
Hi, thank you for your question.
Yeah.
So to answer your question, so I need to get back the purpose of the MDE sequences. So the purpose of this one is assessment the viability of the myocardium. So for example, like MASH, fibrosis, and scar, and so on. So this needed the contrast media to come to see the contrast changes between the blood pool and myocardium. So my answer is we actually can scan the MDE before contrast, but it doesn't gain any value, and I don't see any clinical paper to press the validity to use this kind of sequences for before the contrast. And in the case, if your question is about to acquire some images for assess the morphology of the myocardium in the very difficult patient, they cannot breathe their heart. So the single thought technique is also available, comparable to the black blood imaging. So I hope that I can answer that your question.
Thank you. This sequence is especially for elderly patient or an uncomfortable patient for a very ill patient, right? And could we detect a small lesion by using this sequence?
Sorry, can you repeat your
Could
question?
we detect a small lesion by using this sequence?
Small lesion? You
Yeah,
mean that?
this sequence, can we see small lesion or how many, how big lesion by using this sequence? Yeah.
So at this moment, the protocol we usually recommended, as you can see on the Scmr guidelines. So the slide technique is in every sequence around 8 to 10 milliseconds. Oh, sorry, millimeter.
Millimeter,
So,
yeah.
Yeah. So sometimes it's if if you the lesion is too small, maybe sometimes maybe because when we scan with the light technique like that, there's some average volume effect. Maybe if the lesion is too small, maybe cannot to detect clearly. Yeah.
Oh, yeah. Thank you. Okay.
Thank you.
Thank you.
Before Mr. Dung continue with some question, I have a question for Mr. Nhan and Mr. Nhan, and from GE. You can summarize for everybody in Asia. How many countries uses, for example, like DME technique, DME technique, for how many countries using for cardiac MRI? You can summarize for everybody in Asia, because we want to know, because in next time we can share at version together in next time. Mr. Nhan or Mr. Nhan also, okay. You can summarize for Asia. How many countries use?
As you because right now I'm working as a MRI application for ASEAN only. So in my team, so there we have also in Malaysia, Indonesia, Vietnam, Singapore. I surely that that countries perform the CMR, the cardiac magnetic resonance in their hospital. So, but I'm not so sure about another country, because CMR is not popular much in those another country. Yeah, but for country like Vietnam, right now in Vietnam we perform quite a lot of the CMR. So that is when we using the CMR. When we do the CMR, the MD absolutely need to do. Yeah. So Nhan, do you have any add-on information? You know that another country we also do the CMR.
I think it's Cambodia we have.
Yeah.
Cambodia. Yep.
Yeah.
Maybe Cambodia just in the installation, just install new installation.
We have two sites in Cambodia. They start to do the CMR is at Rai Phnom Penh and Kantapofa Children's Hospital. Yeah.
Maybe in Macau, not yet in Fernando.
Sorry?
Macau not yet, because depends on the cardiologist. Because in my hospital, the cardiologist not commonly request cardiac MRI. I just do 1 or 2 patients per year, mostly to check the morphology of the cardiac. So nothing. My hospital do not have experience about the cardiac. Maybe you prepare to buy a new machine. On that time, maybe they will start again, because my MRI is very old. Need to change another new. During the COVID-19, everything, the project is delayed. I hope it will next year. They will be finished to install and can use. Thank you.
Thank you. Yes. Yeah, Mr. Dung continue with in chat box in have some question. I see. Yeah, Mr. Dung continue, please. Thank you so much.
Yes, thank you. Thank you for all the panelists to discussion with around the topics and with speaker. And I saw some question for your for speaker. The first question is from Indonesia. How to choose the optimum TI for LGE based on kinds of contrast media that we use? Is there any case where AIR DL print make the image too smooth that makes light scan become a new identify? Because when the image too smooth, there will be less on details. Please, Mr. Nhan, answer this question.
I think Mr. Nhan together. Yeah.
Yes.
Sorry. Yeah, I mute myself. So the question it have two parts. So the first part is how to choose the optimum TI for like based on the kinds of contrast media that we use. So for my experience, because I'm working mostly in Vietnam, so now most of the contrast media right now in Vietnam using the DOTARAM. So the basic workflow for this blanket imaging is we need to, after the contrast media, we need to wait for the 8 to 10 minutes to do the other second, like we call in the Cine ER to identify the correct TI inversion time, and then we use that inversion time to use for the MDE to maintain to ensure the legged imaging image quality. So I'm not sure with another contrast. Hopefully, because you are on many countries, so hopefully I can get some information about your countries. What contrast do you use at this moment? Because at this moment, I have just experience on the DOTARAM only. Yeah. For the second part, is there any case where Ericom DL bring the image too smooth that make light sky become unidentified? Okay, so I have not seen any feedback like that on my reason, especially ASEAN reason, because as you know, FDA has approved our Ericom DL feature. About how Ericom DL have to increase the image sharpness. So this is not a filter, it's an impact on the raw data. So I believe that this is not affect on it make the image to move to not to see the very well the light scar I just mentioned. And beside that, in Ericom DL, we have 3 different levels from low, medium, and high. Every time when we application specially come to the hospital to set up the protocol for doctor, we usually scan and make the comparison for the doctor to decide how the image could look like, how the image they prefer. Yeah.
Just on, Mr. Nhan.
Yeah. That's my answer.
Yeah, yes, thank you, Mr. Nhan, for your answer. And I have another question for.
Sorry, Em Dũng. So I also to add, as mentioned in the first part of the question, I also add the idea from the panelists about what kind of contract right now in their country they are used right now, and how the workflow for the legged imaging with you, because right now we in Vietnam, I just only use DOTARAM, so I don't know how the other country, maybe they use a different contrast. Yeah.
Yes, please, panelist can answer the speaker Nhan asked about other country can use another contrast, maybe different name. Because just in Vietnam, just use DOTARAM or Radiographers. So okay. who can answer to him? Please, panelists. Other country.
I can answer. In Hong Kong, the most common contrast what we use in MRI is the deuteram also, same. But sometimes we'll use the Gadolist. You know the Gadolist, the new quite new contrast recently in these few years. Yes, and they claimed that the T1 shortening time is quite better than the deuteram. So in our center, sometimes we use the deuteram for the MRA sequences. And yeah, and as you know that we'll use the PMOVs also for the liver case.
Yeah.
So I think more than 90% the patient in Hong Kong is using the deuteram. Yeah, because the price is quite reasonable and also they're quite safe contrast.
Thank you.
Yeah.
So yes, Macau. Macau is same like Hong Kong to use a Gadolist most and the PMOVs and multi-hands. We not have a deuteram. We know the deuteram, the T1 is not so bright than Gadolist. But sometimes for the brain MRI, because the motion of the vein, so sometimes the deuteram I think is better than to use Gadolist. So depends, but the Gadolist, the price is good. Maybe I don't know the price. The deuteram is cheapest or not because we not have. Just that. Thank you.
Yes, thank you. And
Yeah, in Myanmar, we are using especially Omniscan. Omniscan sometimes before we use magnifius contrast. Nowadays, we are using Omniscan only for MRI contrast.
In Taiwan, in our hospital, we usually use Gadolist and Dotare. But I have one question about I don't know which one is more better for cardio MRI. Which one is more better?
Mr. Nhan, can I answer?
Sorry, no. I cannot hear the question.
Yes,
Okay. My question is, since for cardio MRIs, we have different contrast agent can use for cardio MRIs, since Gadolist or Dotare. So I just want, because we don't have too many experience about it, so I just want to know which one is more better for cardio MRI imaging.
You mean about the legged imaging?
Yeah.
Yeah, actually, I have no experience with using another contrast for CMR, but a member of my team is she also an application specialist in Indonesia. She has a lot of experience with the CMR, so she used to recommend me. She used to say to me that for the get a better contrast of the legged imaging, she refer to use the multi-hands compared to the deuteram. Yeah.
In Malaysia, we use deuteram. Some hospital also use PMOVs and Gadolist. So that depends on hospital, especially the public hospital, because all the contrasts are supplied by contract. So a hospital cannot choose which, but in private, they can use deuteram, but that's the most common one. PMOVs they do for liver, and some hospital use Gadolist.
Yeah, in Singapore,
For cardiac MR, they like my institution uses Gadovis. Yeah, because I think the enhancement is a little bit brighter with Gadovis.
Yeah, in Philippines, we have major companies supplying here for contrast media for MRI. We have Bayer and Bracco. So yeah, we have also, as one participant here made mention from Philippines, they use the Gadovis.
Yes, thank you for all panelists in all the countries for sharing very well about contrast in MRIs and medical ops, but usually still as Gadovis and Dr. Ram is the more of you in the same as Vietnam. And I have more question from question online from discuss the role of T2-weight MRI imaging in assessment of the real arteries in patients with acute myocardial infarction. Some investigators have raised doubt about the veracity and feasibility of using T2-weight image to measure the real artery. Yeah, the question.
Dr. Sơn, maybe Dr. Sơn answer maybe a very good.
Yeah, I think Dr. Sơn can answer this question.
Yes, thank you question. I think you want to diagnostic of the acute myocardial infarction, so very difficult. And I think you should combine a lot of information. For example, you examine the patient, you see the ECG or echocardiography before, and maybe when we scan the cardiac MRI, we have the more information before the T2 weighted T2 mapping. For example, maybe you can see the cine imaging. You see the hypoperfusion in the cine of the image. Continue, you combine with the first batch perfusion. You see, you can see the area of the hypoperfusion, and in the latest, maybe you can see the scare in the especially scare local, especially the subendocardial and subendocardial fibrosis. And I think the information of the T2 mapping, maybe we can see in the imaging in the T2 weighted, you can see the high intensity area, and maybe after that you measurement T2 mapping that area, and you see high the T2 mapping values, and that's you think you combine the more information. You think the acute myocardial infarction so more exactly for you, not only you the T2 weighted mapping only.
Yeah, thank you for your answer, Dr. Sơn. And I just got a message from Indos. Indos also use Dr. Ram too, but the contrast by Dr. Ram you will be just watch out in 5 or 7 minutes on normal EF or LVs around 60 to 65%. Yeah, who can one of speaker who can explain about this message from Indo? Mr. Nhan, can you explain this?
Hi, I think this is just a supplementary information about the time of the washout for the Dr. Ram. It's not this question, I think.
Okay. Yeah, but I think another contrast, maybe a different time. I don't. Can you sharing about the contrast, or it's just about the terrain? Or Gadovis? How about Gadovis?
Get close.
Yes. Yeah, it's okay.
PG.
So thank you very much, speaker, panelists, and all those participants has made the success part successfully. And now please back to Bichi Luna to handle the conference. Thank you.
Yes, thank you very much, our program moderator, Mr. Phi Duong. Thank you very much, dear presidents and our panelists. The Vietnam Association of Radiological Technologists, VART, has provided us with two great speakers who have just shared to us very interesting discussions. In the interest of time, we have to cut from here to give way for the closing session. Again, thank you so much to our distinguished speakers. We have learned so much from your interesting and important presentations. Finally, we are all excited to know about the next exciting online CPD Asia schedule and to address an invitation to tell us more about its exciting event. Let us all welcome the representative from Indonesian Society of Radiographers, PARI, Sir Putu Adu Susanto. Can you please take the, yeah?
Thank you, Vijay. Yeah, I'm sorry I cannot put the background, so I use my phone camera. And thank you, Vijay, and thank you, all President. We very welcome to help the 16th ASIA CPD Indonesia. So it's going to run about in the last month of June, and the topics in pediatric imaging. That's all we can share right now. And the information we will share again later. Thank you, Vijay.
Well, thank you, kapatid, Brother Putu Adi Susanta. We will surely be supporting you and Pari with the hosting of that next big exciting event. So everyone, please see updates and relative posts regarding the announcement of the 16th CPD Asia, which is going to be out soon. So please keep updated always. In closing, congratulations to Vietnam Association of Radiological Technologists, VART, its officers and the organizing committee of the 15th CPD Asia. We thank and support also our sponsor, VT Healthcare Vietnam. We also would like to thank our two great speakers, Dr. Son and Mr. Nhan. And most of all, we are sincerely grateful to all the member societies, presidents, to also our very hardworking CPD Asia IT team, and to all registered participants who have made this online CPD Asia program a success. Again, we see you in the 16th online CPD Asia. Again, I am Peachy Luna and I say thank you everyone. Have a great weekend ahead.
See you, Indonesia.
Okay. Goodbye, Macau. See you next time.
Thank you, everyone.
Thank you, everyone. Good night. Good night, everyone.
Have a good day.
Good night, everyone. Thank
Good
you.
night, everyone.
Good night, everyone.
Good night. Thank you.
Thank you, my
Good night.
sister.
Thank you, the speaker.
See you.
Thank you.
Thank you.
Thank you.
Thank you everyone.